Welcome to the STEIN Fireside Podcast. Obviously, we're not at Fireside for this. This is another interview in the American Association of Neurological Surgeons annual meeting. We're lucky to be able to interview Dr. Benabid, who is the father of deep brain stimulation surgery. I have Dr. Michael Park helping as a co-host from the University of Minnesota, and he is also the chair of the Van Wagenen Society for this year. And the Van Wagenen Society brought Dr. Benabid. Do you want to talk a little bit about that, Dr. Park? Introduce yourself.
My name is Michael Park. I'm one of the Van Wagenen Fellows. The William P. Van Wagenen Fellowship is established by the namesake. He was, I believe, the second AANS president, and he went overseas to train, in addition to his neurosurgical training, to bring something back. And he thought that was a very vital part of neurosurgeons training, so he established this fellowship. It gives the neurosurgeons who are finishing up their training the freedom to go internationally to learn new skills or do new science. And traditionally, they have brought it back to the U.S., and that has continued since its inception. And there's one chosen every year. Dr. Kai Miller was one many years back. And we gather every year to celebrate the fellowship, but we also have invited special lecturers to give lectures on either their scientific activity or their discovery. Now, this year was very special. I think when we sat down and decided upon the potential guest speaker, I think it was pretty unanimous when we said, we should have Dr. Benabid. He also mentored some of the previous fellows, and that's one of the sort of the requirement. And so we thought it would be wonderful. Now, we weren't sure if he was going to say yes to it, but he graciously accepted the invitation. And we just finished it's a sort of celebration, sort of on our own, to honor Dr. Van Wagenen, of course, and all the previous fellows who've gone on to do great things, and to try to inspire the new generation of neurosurgeons to participate in the fellowship. So here we are, and we're happy to have Dr. Benabid, of course, who needs no introduction.
Yeah. I was lucky to be one of the Van Wagenen Fellows. It really helped steer the course of my life. Part of what I've done since I was an early resident is in order to learn different tips and tricks from senior neurosurgeons, and this is really anybody in functional neurosurgery. I started this group that we call the Society for Technology, Engineering, and Innovation in Neurosurgery. That acronym spells out the word STEIN, and this is a STEIN. So people come join in the evenings, and we have a drink together, and then we talk about neurosurgery and the different things that we're doing. And it's sort of a social event, but from this social event, I've learned many tips and tricks about how to do surgery. Now, something that was very interesting for me was when you were giving our Van Wagenen luncheon talk, and you showed the different stages of deep brain stimulation surgery and your development of it. Everything to me seemed very well established. We've known this for a long time. This is everybody who does this surgery knows this. And of course, that's true. And the reason that we know these things is because you figured them out. So I think on behalf of every functional neurosurgeon in the world, and certainly all of us, what you've done for humanity, I think, is an amazing thing.
Yeah.
And so this is very nice. On the
very
podcast.
Nice to hear that.
Yeah. Well, I mean, it's hard to be too superlative when we're interacting with you. I think many of us feel that your contribution to treating and understanding the brain is one of the biggest contributions in history. And it intervenes with how the brain functions. I know that you've certainly been nominated for the Nobel Prize before. I know you won the Lasker Award. Yeah. I've talked to people who are involved with the nomination process, so I know that you're nominated.
Yeah.
So usually we begin these interviews with trying to understand where people started from and how that led them into their path related to neuromodulation. Can you tell us a little bit about growing up?
Yeah, I mean, my father was because he died an MD, and I was raised all my life in the ambience of people having troubles and doctors having the goal and the duty to solve those troubles. And it was all my life like this. My father never told me what do you want to do. He was saying you have to be an MD and in the best way you can. I said, well, I'm interested in physics too. So what? Where's the problem? Let's go to Grenoble. I know because he was raised also in Grenoble at medical school. And there you can register to the faculty for science and go to medical school. This is what we did. And then by circumstances, you meet people who help you or give you ideas, etc. Particularly my mentor, Professor de Rougemont, was a wonderful guy, I would say. Sir, could I try this? He said, you try whatever you want, but if something will happen, come to tell me before.
Yeah.
So it was the ambience, this energy and pleasure of doing things. And during surgery with Professor de Rougemont, he was extremely, I would say, outspeaking, bavard, when we talkative.
Yeah, sure.
So he could not do something without saying anything, and particularly making comments about what he was doing, what you should not do, etc. And then when I became one of his fellows and said, could I do this? He would say no or yes, if it was clear that I was wrong. If he didn't know, he said, well, try it, but if something happened, call me first, and then we'll see what to do. So this type of freedom, if not obligation, to find something, and having the background of be careful because you are not in a lab, you are in a patient.
Yeah.
And if something happens, you cannot say, oops, I will do differently. You have. So this was a wonderful ambience.
Yeah.
Every time I had a new idea, he said, okay, Ben, do it, but call me if anything is going to happen.
Okay. And then you tell me a little bit about physics. How did you I also have a physics PhD.
Oh.
There's you, and then there's this guy, Stan Anderson, and I don't know if there's anyone else who's done a physics PhD.
Well,
in neurosurgery.
Grenoble it has 2 Nobel Prizes in physics, I think. It's a university which is basically a scientific university. Medical university is important, but physics, and there are several Nobel Prizes in physics who were working in Grenoble. They built up a nuclear center, one of, I think it was the second nuclear center in France, and then you could have the possibility during different occasions to have a stage, or do you say a stay. You can register, I would like to spend August month in a lab of Mr. So-and-so who is doing that.
Yeah,
And then you would go as a student. You don't have to apply formally, except that showing that you are understanding a minimal.
Yeah.
And then
at the beginning of your PhD.
Yeah.
Yeah.
And there were two Nobel Prizes in physics in Grenoble. So it was an ambience. And physics was a matter of life. Everything was.
Yeah.
And including the doctors, you say, well, what is the difference between a physicist and an MD? In physics, the subject doesn't move.
Yeah.
So it was a joke, but a very nice ambience. And then having the possibility to do medical studies and physics studies at the same time. Grenoble is a small city.
You did them at the same time?
Yeah,
Yeah.
just after what we call baccalaureate, which is the end of primary schools.
Yeah.
So then you go to university, you can go to whatever you want. You have to apply. It helps when you know people who know that you are not joking too much.
Yeah.
So I registered to medical school because it's the longest, and my father was an MD. But also I had a lot of friends and knowing people who knew me, who knew my father also, etc., which allowed me to come into the labs and see what is the lab, the life of a physicist
Yeah.
in a lab. What are they doing?
Yeah.
Well, they are doing whatever they want, and they do, and they tell you, and it was a wonderful training time. I spent more than 15 years in different stages.
Yeah.
And then I got a PhD in physics.
Yeah.
And then in medical school, I wanted to do application of physics to medicine,
Yeah.
which was quite easy through different tools, radiology particularly. Everything electrical was easy to come in. And then after a while, people know that you are an MD who is going to be a physicist. Oh, what happens? Well, we'll see what happens. And
Yeah.
it made everything easy. It made everything
Yeah.
easy, so you could enter labs, and then you know how life happens. So you become acquainted with that and that persons. They are doing something. And Grenoble, they built up one of the first places in France where they built up a nuclear center, including research, high-level research, accelerators,
Accelerator.
Yeah.
and nuclear.
And was your graduate work in an experimental lab or in a with a
Well, I did
theoretician?
have a lot of graduate.
You moved through different labs.
So I graduated. I have a PhD in physics,
Yes.
and similar at the same time I went to medical school,
Yeah.
and it was rather easy. So
early
it was
MD, PhD, true
Yeah.
physician scientist. Yeah.
What was the topic of your thesis?
the thesis. The first topic was to learn essentials about the activity of particles on the brain. So it's application of physical radiation, including radiotherapy, etc. And then it started very quickly to have what we call Curie therapy. Curie is the physicist.
So looking at
Madame
absorption
Curie.
spectra of the brain, or
Well, or using insertion of pellets to make
Radioisotopes.
lesions,
Yeah.
or study because of the nuclear center. Many groups were looking at what happens to people working close to a nuclear reactor. And so it was kind of and physics was part of us and
Yeah.
part of course, medicine. And when you know that you can treat someone by having X-rays or having inserts of isotopes, and then accelerators. They built several electron accelerators. Then from this, quickly some doctors came to the physicists and said, could we use those beams, high energy beams,
yeah,
to do what we used to do with basic radiation therapy? So it was,
Early stereotactic radiosurgery.
yeah.
Yeah.
And then when I wanted to do stereotactic, I think I was the first, except in Paris, there is another group. I was the first in France to implant isotopes
Wow.
for tumors.
okay,
So, and tumors is neurosurgery. implants is radio surgery, but it's physics also. So after a time, you don't know who you are, what you are doing. We are doing something which encompasses all the availabilities, and then we could do. Then I wanted to build inside the medical university small lab where I could do experimental surgery on essentially rats. Monkeys came later for electrodes.
Yeah.
So it was an ambience, you know. If you were just doing something, people would say, "What are you doing with your free time?"
Yeah.
Or you're
Oh,
so
wow, that's
stupid that
very interesting.
So, yeah, it was normal. You had a tendency to do what you are not doing, depending of the need, of course. But there are so many needs, so it was easy.
Yeah. What was your thesis topic?
My thesis topic, finally, the real part of it was mathematical modeling of intracranial pressure.
Interesting.
Oh,
Okay.
interesting.
So
Intracranial pressure.
basically, you take a monkey, or we were not too much working on monkeys, but too close to human. So in dogs, I was working on so my MD thesis was intracranial pressure in human with implanting initially just a stopper with
reservoir.
a tube or reservoir,
Yeah.
and then measuring, and then we obtained that someone designed an 1 centimeter diameter intracranial pressure recorder, so we could insert it in human with the hole, and then started this way. And then having those data, you have to treat the data. So you go to the department where they do some statistics, and I brought them what happens. I record in a monkey or even rats, but essentially in monkey and dogs. You put this plug, which measures intracranial pressure, epidural, so it's applicable to human because it's safer than putting a catheter into the ventricle.
Yeah.
And then you anesthetize the dog, you put a sub-occipital puncture, and then we insert volumes either on a continuous way, what we called linear tumors,
Yeah.
or sudden volume, 2 ml of CSF, and then you record the pressure. So when you inject this way, you have a pressure which goes down.
So you can look at tissue compliance as a function of time.
Exactly.
Yeah.
And this is raised by the elasticity of the brain, but also the ways through which CSF goes out of the cranium. So you study and you give a coefficient of filtration to this solution, and you establish an equation. So I was doing this mathematical modeling of so-called physical or medical situation. So either by single injection, what we call echelon, which is a stack,
Yeah.
or with a linear rate for a given time, then you get another type of curve, and combining those two curves, you get information on the filtration system and on the elasticity of the brain.
Yeah.
And you go to equations which are most of the time exponential or 1 minus an exponential.
Yeah, a decay function.
Yeah.
Yeah.
And then when we saw that, we thought that it could be applicable to human.
Yeah.
So going back to neurosurgery, making the burr hole, having those plugs made by a company locally subsidized by the nuclear center, and you could have the equipment and do mathematical. So my first MD thesis was to look at what happens when you do that, inject or continuously. And then the second, then I went to physics and I did a more complicated thesis for several years, combining different ways to change things in the brain and derive from that equations which give you information about elasticity of the brain, etc. So it was this combination between mathematics, easy, physics, simple, medical, justified by the needs, and then when stimulation came, etc., it was easy to integrate that. I got a lab from the university. We said, okay, instead of being alone like this, so we created the neuro lab, experimental laboratoire expérimental de neurochirurgie, experimental lab of neurosurgery,
Yeah.
which provided a lot of mathematical data. We created models, and my PhD thesis second PhD thesis was to have complex studies of those systems, then going to mathematical analysis of physical data, which was easy because you go next door, you see the mathematicians and say,
Yeah.
this is the problem I have, can you help me? Of course we do.
Yeah.
So it was wonderful ambience.
Yeah. Well, as a physicist, you define boundary conditions, and then the
Yeah.
mathematical expressions that you derive that satisfy those boundary conditions become the rules that we have to understand. So understand
And then
physical
we
relationships.
moved to electrical stimulation, and what we are doing now. Then we did with the stimulation, we also developed recording capacities, for instance, grids of 64 electrodes on this surface
Yes.
that you implant against the dura in patients with motor deficits, for instance. We record this activity, and at the moment what we are doing is taking those data, building a model to activate an exoskeleton for tetraplegic patients.
For what you're doing now, the WeMagine device?
Yeah.
Yeah.
So I showed the other day, it
Yeah.
didn't work very much, but we have a patient who is tetraplegic, sitting in a wheelchair. He's equipped with 2 sets of 64 electrodes. In the back, he has a computers
Yeah.
and he's sitting, and there is another wheelchair which has motors which are piloted by electrical.
Yes. By his brain signal.
So I have it here, I showed it, you remember, didn't work very well for it. But we have made something which is called the Monaco circuit, Monaco, the race.
Yes.
So there is a big part of my lab where we have just put plots with a wheelchair motorized and sitting in a chair, this patient who is tetraplegic, but equipped with 2 implants.
Yes.
And he's looking at that, and he's driving the chair between those different obstacles. This is why we say that the Monaco circuit,
Yeah.
the race, the
I do.
Monaco
Grand
race.
Prix.
So, and his job is to put this all the way down, and
You work closely with Dr. Chabardez with that work, right?
he is one of my students. Yes.
Yes. Yeah. You've had many students, and
Yeah.
many of those students came here, right? So I think 3 individuals I've been lucky to get to know and learn from in American functional neurosurgery are Dr. Bob Warren, Dr. Kelly Foote, and Dr. Kim Burchill. And all of them, at some point or another, have told me about their time spent with you in Grenoble, learning about the deep brain stimulation technique that you discovered and then pioneered.
Kim Burchell, I had a long-standing relationship.
Yeah. Can you tell us a little bit about how you discovered deep brain stimulation as a tool?
I was doing functional neurosurgery, as every neurosurgeon does, and particularly for movement disorders.
Yeah.
And one way, the classical way, was to put an electrode in stereotactic condition. I was lucky also because one of my friends at school created a company making robots, and the Rosa robot, I don't know if
Yeah.
we made it together, and so I have one, two maybe at the moment, where you can pilot this robot, and we were using this robot to implant cannulas or
Yes.
electrodes in different places because can be stereotactically guided. So at that time we were doing as everyone would do, which is to put a cannula in the ventricle, have a ventriculography, or using CT or MRI to target the place you want to go, thalamus, the subthalamic nucleus. And then when we have this going down, you can stimulate, but the intention was initially to destroy the targets.
Yeah.
Thalamotomy, this is for tremor, you stop that. The problem with thalamotomy is destructive, it's not reversible. If you make a mistake, it's done, it's done.
Yes.
So how could we do that more safely and being in the right target, not being in the pyramidal track a few millimeters below?
Yes.
So I used to stimulate every place where we wanted to make a lesion, stimulate it at low frequency to test the surrounding.
function.
Yeah, test function.
Yeah.
And if you have tingling or so you should move a little more medial, etc., etc. And doing this, just playing with voltage is not very funny. Because what happens at different frequencies? Should I stimulate 2 hertz, 20 hertz, 1 hertz? So just doing this, you see that at low frequency you excite what is excitable. If you go to higher frequencies, you don't necessarily have this, or you have it more. And in some places, we happen to see going to do a thalamotomy that instead of having any tingling anywhere, the tremor would diminish. So stop it, then try it again, diminish, let's try a little bit more. My boss was saying, do whatever you want, but it's going to be worse. Call me first.
Yeah.
So we were looking at that, and then you see that 60, starting at 60, up to 80 and even more, the tremor would diminish. Oh, and what do you feel? Well, comfortable, no tingling, and then you stop it, tremor occurs. Oh, then try it again, and after a while you say, maybe we could stimulate it permanently.
Mm-hmm.
So that's easy. We have electrodes, we have deep brain stimulators that we used for ventral, posterolateral stimulation for pain,
Yeah.
and it worked. So let's connect it. And this is how it started.
Did
And every time I was calling my boss, Jacques de Rougemont, saying, hi, please, what do you think about that? How are you doing it? So I would explain. Can I keep going? Yeah, but if something wrong happened, call me first.
yeah, of course. We're using the Ogeman stimulator box.
Well, at that time there was one stimulator which was Medtronic, or I was using lab stimulator. I don't remember, WPI. It was a French company
Okay.
used for experiments in rats, etc.
Okay. Interesting. And then, of course, people came to train with you, learned your techniques, and brought them back here. something that I still use in all of my cases that carries your name is the Ben Gunn
Ah,
holder.
Mm,
So
yeah.
it has the, the 5
yeah, because we were
tracks.
doing one track, it's okay, but what about being 2 millimeters, etc.? So finally we came with this barrel 5, descended 5 electrode, Ben gun,
Yep.
Ben.
I understand.
And then you would doing in one way, recording on, they were separated by 2 or 2.5 millimeters. So
Yes.
rather that side.
Yeah.
And you have 5 micro electrodes, used the same one that we use in rats or in the lab. You record, we have multiple recording sessions, so we brought progressively physiologists, etc., who were interested. And then when you have done this, you have five curves corresponding to the stimulation and the effect on the tremor. And you see that channel 1 and channel 2 stop tremor, the rest not. And channel 5 give you dyskinesias or whatever wrong.
Now, I've in episodes of the podcast that will be coming out shortly, I'll talk about microelectrode recording, and of course, the microelectrode recording and test stimulation that I do is really based on people that you taught that then I learned from. Can you tell me about how you developed microelectrode recording as a component of this surgery?
Well, just because I was doing already micro-coding for basic studies as a physiologist and during experiments before without the patient. So we were very accustomed to that. There were several labs working with microelectrodes in different situations, even with very specific electrodes, glass electrodes, etc. So integrating this in our operating room was just a question of, can I do it? Yes, do it. And we spent a lot of time. And every time I would go to Jacques de Rougemont and say, sir, can I try this? 5 electrodes at the same time? Well, that's your responsibility, but if something was wrong, call me.
Okay.
So we are doing this, and then it was a very good exploration because in one session, you would choose which is the good place for the chronic electrode
Yes.
instead of trying moving a little bit more or less. And then you remove that and have the electrode going down. And this is a good cooperation with Medtronic. We had a monopolar electrode, 3384, I think they called it, which was used for different situations where you need to stimulate and connect it to their IPG,
Yeah.
particularly for Parkinson, but also for some forms of pain. We used to have these 5 tracks, and then we could decide out of the 5 tracks how much are we going to replace them with electrodes, monopolar electrodes. But monopolar, the problem is how deep must you go?
Yes.
So a solution is I take one electrode which gives me several levels.
Yes.
So instead of one, I have chosen the track which is apparently one of the good ones. Then I replace it by a 4 contact electrode.
So were they 4 contact leads from the start, or were your initial leads single channel stimulation that you implanted in patients?
No. Then you connect it to IPG, 4 contact IPG. This did exist. The electrode was 3389, and the number of the IPG.
Yeah.
But then you buy it from Medtronic. You can connect for each side, and then we had simulators where they had 2 outputs, and then from along one track you have an electrode which has 4 contacts,
Yeah.
separated by half a millimeter. It covers about 4 or 5 millimeters long. So once you have done this, you have either you can make even also several implants at the same time, having several electrodes. So it gives you a kind of special matrix of electrode, which when the patient is out of the operating, even if you don't have fully implanted the IPG, implantable pulse generator, then you can, during the days following, find out which is one or two maybe contacts along that line and the other one. And at the end of the week, the patient is fully equipped. And most of the time, we didn't need to do something different because we had covered. And amazingly, putting those 5 electrodes, if needed, sometimes 2 were absolutely enough, then you have a patient go back to his room, you finish all the pansements, we say, putting the closing the skin and having a gaze, and then sparadrap, sticking, those things. When you have finished,
Dressing?
you cover with
Dressing.
with something which sticks to the skin.
Yeah, an adhesive dressing.
Adhesive dressing.
Yeah.
Bandage.
So they have to. And
Would you typically start out with bilateral trajectories, or would you go one side and then the other side?
Well, at the beginning, we wanted to know what would happen, but very quickly we say, won't use, depending on the patient. If you have a unilateral tremor, useless to go two sides. But most of the time, we had severe patients that they would go out of the operate. They would be operated bilaterally with 2 stimulators. Medtronic very quickly came with a stimulator where you could put 2 4-contact electrodes.
Yes.
So it was then extremely easy for the neurologist to come to the room of the patient and spend the time needed to optimize the results. And we have done, I don't remember how many patients, and then this spread a little bit. So I think it was a good solution.
Well, we're lucky to have Dr. Park as a host today, along with me. Typically, the host for the podcast is the movement disorder neurologist that I work most often with, who's with me in the operating room, and I also work with him outside of the operating room and in the lab. Did you have a particular movement disorder neurologist who you did much of this with?
I'm not sure I understood you.
Was there a particular neurologist who you had your work with?
Well, Grenoble is still a small university, so we didn't have 100. They were all hospital practitioners. So I was a neurosurgeon with 1 or 2, depending on the evolution of my group. But we came up with 3 neurosurgeons and the neurologists, because they were doing something else than movement disorders. There was a bunch of 6 to 10 neurologists, hospital neurologists, full-time.
So you would work with different neurologists in this process?
Yeah. Or quite often during the practice before surgery, the patient was connected with that neurologist more than to this one. So this,
would they come into the operating room with you from the start?
They were
many of us have now?
advised to. They were advised to. That is simple. Say, if you don't come and I make a mistake, this is your fault.
Yeah.
So come with me. We do the surgery. We agree that it is 2, 3, 4 electrodes that we need, or 1 with 4 contact is enough. At the end of the surgery, everyone has agreed that, okay, we have done the best we can do. Then the surgeon has to shoot the skin. And then there was continuous interplay during the days after we would go and see the patient at the bedroom to make sure that
With the externalized leads, you could test different
yeah,
hypotheses.
but very quickly we did not externalize leads.
Yeah.
When we had very good result during surgery with 1, 2, 3 electrodes, then we would go right away to this, we'd implant the IPG, and it would be a long surgical session, starting in the morning, finishing at the end of the afternoon. But when they go out, they are totally finished. The neurologist has been there. He doesn't have to come back and say, hey, I don't understand what happened. You were there.
Yeah.
So,
I think it's wonderful, especially for our viewers, to know that it's been a neurology and neurosurgery partnership from the start in neuromodulation.
yeah.
I've heard stories that in the beginning days, you guys would take lunch breaks during the surgery briefly. And so you would leave the operating room, have lunch, and then come back because the cases would last the whole day. Was this true?
Oui. No. Yeah, because we took advantage also of doing physiology. I mean that even as a neurosurgeon, I'm very interested in physiology and in the physics that you can
Yes.
derive from that. So we were equipped with systems making online analysis, online frequency spectra of what we were recording. So, and then you have the week or the days after to work on that. But at the end of the day, we have, I would say, exploited at maximum the patient. He doesn't come back, because if he does come back, means that we did something wrong, and by definition, we were not allowed to do something wrong.
Yes.
So we were in situation. No, it was a wonderful time with the young students, nurses also, where some of them said, "Well, I would prefer to go for this surgery rather than going for spine surgery."
Because when you watch this in the operating room,
Yeah,
this is the most magical thing in medicine.
yeah, and you, besides that, you're part of a team.
Yeah.
So we are a team in neurosurgery. We were at the time, at my time, when I finished my time, we were 6 or 7 neurosurgeons. The nurses were about that number or so. So it was a group doing this. In addition, we are doing also epilepsy. Epilepsy, sometimes the people were slightly different because we needed more epileptologists for different. So the team, the neurosurgery team at the time when I left it, was a big event.
Yeah.
A big one.
And then I think because many of our viewers are Americans, can you tell us about your experience with American neurosurgeons coming to visit you, and then what it was like to see this thing that you developed in France make its way not just to America, but all around the world? How has that experience been for you? I mean,
Well, meeting people is always wonderful time. And those who come and see you are not stupid people usually. So it's a social and private experience, wonderful. I knew this way a lot of neurosurgeons from the States, from France, and from all the country in Europe. So it was a spirit. It was not a church.
yeah.
It was a community. And some were interested, for instance, in dystonia,
Yeah.
and others in Parkinson, others in. So we would have subgroups. Usually, dystonia was not necessarily those interested in Parkinson, because the patients are different.
Yeah.
But no, it was a wonderful time. I miss it.
I treat a lot of children with dystonia, and they are non-functional. And I remember watching Phil Starr, who you may have met, do this when I was a medical student. And my residency application was written about dystonia in children. And now I'm about 2/3 pediatric, 1/3 adult. And I got a picture yesterday. We have, there's something called prom in America, which is when you're in high school, you go to a dance. And one of my female patients, she's 16 years old.
She won the contest.
I just saw her mother sent me pictures of she and her date dressed up, and seeing her there when she came to me, she was very she was very disabled by dystonic posturing. She really couldn't function normally, and I mean, it was a magical thing to see her living this life. And you know, I have the ability to do this. I just want to say thank you because of what you did. I have the ability to do this for these patients. So.
And
It's a magical
besides
thing.
movement disorders, there are also psychological disorders.
Yeah.
So OCDs work
Yes.
very well,
Yes.
and we have a lot of patients, and they are very disabled people
Yes. Very.
because there is no real good medical treatment, but with a good placement of electrodes most of the time, then we give back to those patients quite normal life.
Yeah. I have some of my children have Tourette's with comorbid OCD, and then we actually target, you know, the VCVS nucleus accumbens lead, something that captures both, and then centromedian nucleus at the same time to sort of treat both etiologies. I don't know, in the adult population, have you had much exposure to this?
Dystonia?
To psychiatric indications?
Yeah. So at Minnesota, and you met my colleague. I think he was on your podcast too, David Darrow.
I've been
And,
trying to get him.
Oh, you have been?
Yeah.
Okay, we'll
get
try
him
to get
soon.
him.
This will be pressure because he'll be on video.
And we have a psychiatrist team that are very pro interventional. So like Dr. Alec Widge has a protocol. So we have treated OCD patients with DBS electrode, and we do
OCD
map
is
it.
very good indication.
Yeah, we actually do map it going way down to listen to cells, but they're very few and far in between. The biggest hurdle that we face, I think, as American neurosurgeons, is that even if we wanted to do something pioneering like this, it comes down to who's going to pay for it, right? I believe in France, if a physician decides this is something that we're going to do, the government is going to pay for it.
That's what we call social security.
Yeah.
Whatever you do in France for French people or acquainted, there are some situations where you can benefit from social laws. I would say all the immigrants, for instance, North Africa, etc.
Yes.
Even if they don't have fully, most of them, they get it easily. But if they don't have the national identity card, they can be included, given good circumstances, in this system, and then it's full coverage. The hospitalization, the drug, etc., etc.
So, like, your hospital didn't come to you and say you cannot connect it to a pacemaker because it's experimental. We're not going to pay for it.
No.
If you said it's going to work, so I'm going to put it in, the French government would say, go ahead and do it. Whereas we are faced with that. We know it works. We know we've seen it work, either through research, experimental protocol. But when we actually want to do it, we have a challenge. Insurance will say no.
No. Well, that's much easier in France because the insurance, private insurance, I don't think they exist, or they just add something. But the insurance is national social security. And once you are in the hospital belonging, and the private clinic, I think they can have easily an agreement, etc. But they are not so frequent in this situation.
I think that's the beauty of it there, is that...
So once you enter, let's say, my department, or my former department, if I decide that this patient needs 3 electrodes here, 4 here, plus whatever here, because I am the appointed neurosurgeon, or the head, or even not the assistant, it's strongly depending on the agreement of the head of neurosurgery. So if you have a team of 6 neurosurgeons, You don't have 5 doing this and the 6th one saying, no, I don't.
Yeah.
You have the head who says, this is a policy of the department. We have meetings when the patients are included every week. What will be the program for next week?
Yeah.
Everyone shows what is the list of patients. We can discuss. Someone may say, there might be much better to do the other way. So that's very interesting. But once it has been decided to be operated, that's a question of managing the time chart. This is the head nurse, you say?
Head
Yeah.
nurse.
Sure.
Who
Nurse in charge. Yeah.
nurse in charge who will say that this ruse is not available that day because of that. So they manage. We don't have. But the government does not interfere. Once someone is included in a hospital or hospital appointed government appointed hospital, then it goes by itself. You don't have to negotiate, and particularly the head of the department is extremely powerful. If you say
Yeah.
this will be that, then we discuss between the neurologists. We may have to go to the head of the hospital. Usually, he hears that I called. I wanted a rendezvous with him, but he said useless to
Yeah.
waste time.
Yeah.
So that's
And it sounds like early in your career, you really benefited by having a head of department who was supportive of you and said, you only come to me if there's a problem.
the head
or
of
not,
the
you only come to me.
department was and is extremely important because in finance, he is the one responsible.
Yeah.
So if something goes wrong, justice doesn't happen too much. But if it happens, then it will go and see the head of the department. What happened? Why did you?
Yes.
And most of the time it's okay.
Because their judgment leads.
Yeah.
Well, that's wonderful. In the podcast, we also sometimes ask people about the joy of living the life that they lead, whether they're scientists or engineers or neurologists or neurosurgeons. Can you tell me about the joy of a life in functional neurosurgery?
Oh, of course it's joy. Well, I would say, I think most of neurosurgeons are happy to do what they do.
Yeah.
So it's always, then you like more or less this part of your field of, for instance, what I don't like. I cannot tell you what I don't like because I don't do them. So
Oh, that's
no, I
Only
mean,
do what you like.
there is enough work. If there is a problem, because who would be then the head of the department who say, Ben, come and would you do this? When I was the head of the department, this was the way I was going. And I knew that this one was good for that. He would spend time. The protocols are usually decided in group. There is a philosophy in my, let's say in my or whoever department, they won't operate dystonia in 3 different manners. They will do it or not because they are good at that or not, they are interested or not. But then if you have 10 surgeries per day, never happen. 10, let's say 10 surgeries per week, and if you have 5, 6 neurosurgeons, well, on Monday morning we do the chart for the week or for the next week also, and it goes without any problem. No. Plus the engineers and the impact of having the engineers who come, and the engineers, I would say respectfully, they do what we tell them to do.
Well, I mean, we do have situations with commercial hardware sometimes where the engineers tell us what we want, instead of listening to what we want and engineering a solution based on that.
Well, why
In
not?
some cases.
Why not, particularly when there is a new device?
Yeah.
if you have 5 neurosurgeons in your team, Medtronic comes with a new 4-channel, 100 frequencies, etc.
Yeah.
It's not clear that all people would know how to use them. So there is teaching session exchanges between the company and the head, and the head will decide, because you know that it's useless to ask so and so to do this, because he won't do it for whatever reason. So that's no. Normally it's okay. We don't have no problem of reimbursement because it's discussed before with the hospital. And if you are doing well, the hospital knows that if you do something, it will be well done. And if you come and say, I would like to try something else, they would say yes, because this will be an add-on, a plus
Yes.
for the group. They trust you. But if you do mistakes, that's something else.
Well, I really want to thank you for coming on our podcast. And I'm very grateful for everybody that's watching from wherever you're watching from today on YouTube. And thank you, Dr. Park.
Thank you for having me.
It's an honor to have been able to interview you today.
No, it
Thank you
was
so
an honor
much.
for me.
Yeah.
It was an honor for me, a pleasure.
Well, it's been really an honor. Thank you so much.
It's been an honor to be invited and to be interviewed, and I enjoyed it very much. And
Thanks.
Thank
you,
Thank
Dr.
you.
Park.
Yeah, thank you.
Yep.
Thank you, Dr. Benabid.
thank you.
Okay. All right.
Yeah, thank you.
Good. Thanks, everyone.